This is pediatric physical examination part 3. It is about examination of the respiratory system. Inspection, palpation, percussion, and auscultation remains the cardinal approach to physical examination in pediatrics like that of adults. When we start from inspection of the respiratory system, first on inspection, examine the shape, inspect from the front and back and also from the side of the patient. Normally in infantis, the thorax is round. And there are different shape abnormality in children. From this, the first one is pig chest or pectus carinatum. This is protrusion of the sternum anteriorly. And pectus carinatum is external deformity, which accounts for 5 to 50% of congenital chest wall abnormalities. And anterior displacement of the mid and lower sternum and adjacent costal cartilage are the most common types. They are most commonly associated with protrusion of the upper sternum, and depression of the lower sternum occurs in only 50% of the patients. Asymmetry of the sternum is common, and the localized depression of the lower anterolateral chest is also often observed. And the males are affected 4 times more than females in pig chest or pectus carinatum. There is also highly familial occurrence and the common association of mild to moderate scoliosis. Mitral valve disease, coarctation of aorta are associated with these anomalies. The other abnormality of chest shape is the so-called final chest or pectus carinatum. This is depressed sternum. Pectus excavatum or final chest is a midline narrowing of the thoracic cavity, and it's usually an isolated skeletal abnormalities. The cause is unknown, and the pectus excavatum can occur in isolation or it can be associated with a connective tissue disorder such as Marfan syndrome and Ehlers-Danlos syndrome. It might be acquired secondary to chronic lung disease or neuromuscular disease or trauma. And the pectus excavatum occurs in 1 in 400 births with 9 to 1 male predominance. And this one, or that means pectus excavatum accounts for greater than 90% of congenital chest wall abnormalities. There is a positive familial history in 1/3 of the cases. The other abnormality in chest shape is barrel shape, and the other one is Harrison sulcus, which occurs in rickets commonly, and also Harrison sulcus occurs in asthma. And the other thing that we inspect on the chest is pattern of breathing. There are different types of breathing. Apnea or cessation of breathing for over 50 seconds is one type of pattern of breathing abnormality. The other is kinestroke breathing. That means increasing rates and the depths followed by decreasing rate and the depths of breathing. The third one is Kussmaul type of breathing. That means fast and deep breathing, that as it occurs in acidotic patients such as DK. So there are different patterns of breathing, and we should have to inspect the shape of the chest, the pattern of breathing, and also inspection of the chest includes inspect the expansion, symmetry, and retraction, intercostal, subcostal, suprasternal traction, and the like. And listen for the character of the cough also. And also check whether there is any audible wheezing, stridor, and the grunting, and also any hoarseness of voice that can be audibly heard. And also inspect the fingers for clubbing, and also inspect the lips and the tongue for bluish discoloration or cyanosis. Cyanosis occurs when the concentration of deoxygenated hemoglobin is 5 gram per 100 ml of blood. So, in severe anemia, in spite of hypoxemia, cyanosis may not be detected as there will be no enough hemoglobin to be deoxygenated to result in cyanosis. So, in addition to inspecting the lips, tongues for bluish discoloration or for cyanosis, inspect the fingers for clubbing, and the clubbing is around rounded curving nails, increase the thickness in the spongy and the consistency at the base of the nails, and also a loose of the normal concave curvature where the nail base meets with the proximal digit and the bulbous enlargement of the digital pad. There are different, this image shows different chest wall abnormalities. The first one shows depressed sternum, that means final chest or pectus excavatum. This one accounts for 90% of chest wall deformities. And the second one shows the pig chest or pectus carinatum or protrusion of sternum anteriorly. And this causes increased anteroposterior diameter of the chest, and it decreases chest excursion and the expansion during breathing, and so it causes increased in residual volume during breathing, and it affects the different functions of the lung and also cardiac activity. When we see the different stages of clubbing, there are around 4 to 5 staging of clubbing based on the different textbooks that we used as a reference. Grade 1 is, or stage 1 is referred to as softening and the fluctuation of nail beds, whereas grade 2 is referred to as loss of angle or obliteration of a nail bed and the proximal nails of proximal nail folds, and grade 3 is increased convexity of the nail folds, and grade 4 is thickened distal phalanx, and some call grade 5 as a hypertrophic osteoarthropathy. So we should have to grade the clubbing when there is clubbing in the children. The second part of respiratory system physical examination is palpation. Examine for areas of tenderness on the sinus and the chest wall, and also check for crepitation for subcutaneous emphysema, and tactile fremitus should be checked, and it can be done while the infant is crying in young children, because young children are not cooperative as that of adults. We can do it when the baby cries. Position of the trachea should be checked. It can be determined by putting the middle finger in the suprasternal notch, feeling and comparing the space between the trachea and the sternocleidomastoid muscle with the index finger and the fourth finger. In small infants, assessments should be done using only the index finger put in the suprasternal notch. The tip of the index finger is pushed backward to determine the space on the either side as mentioned above. This is how we can determine the position of the trachea. The third one is percussion. Both sides should be percussed to examine both sides of the chest, both anteriorly and posteriorly, and also we should have to compare each side. Percussion, use light percussion. Both sides should be percussed as I have said, and they compared, and normally the chest is resonant to percussion. There are other sounds. If the normal one is resonant, and dull percussion note is due to solid lung that does not reflect sound as readily as aerated lungs, or mass or fluid that obstructs transmission of sound to the chest wall. So dull percussion note is due to either consolidation or collapse, and the stony dullness is due to fluid or effusion. Hyperresonant chest is due to it occurs when there is air in the chest out of the lung tissue, and it is due to most of the time due to pneumothorax. And the coin sign can be elicited in pneumothorax using one coin as a plexer and the other as a pleximeter. Metallic sound can be heard on auscultation on the opposite side on auscultation. This is the order in which we should have to percuss the chest. We should have to compare each side. We should have to go in the zigzag pattern to compare each side of the chest, both anteriorly and when we came to the third part, the fourth part of physical examination of the respiratory system, that's about auscultation. For the beginner students, the cries of the baby might be frustrating. Usually, children do not cooperate when asked to breathe in or out deeply. However, during crying, the student should synchronize his listening with the inspiratory phase when the baby is taking deep breaths for the next episodes of crying. Normal breath sounds include bronchial breath sound over the trachea and the major airways, and in the rest of the areas it is most of the time vesicular or bronchovesicular, but on most lung-filled areas it is vesicular. Listen for the phase of breathing, listen for expiration and inspiration, and expiratory phase might be prolonged in obstructive airway disease. Additional sounds, that means the normal breath sound is vesicular in most lung-filled areas, and various types of sounds reflecting abnormalities could be heard. From this, the first one is wheezing. Wheezings are produced as air passes through a narrowed airways. That means when the airways are narrowed by disorder like asthma, bronchiolitis, and the like. The other is rhonchi. These are continuous and snoring sounds due to partially obstructed bronchi by inflamed mucosa or secretion. Sonorous rhonchi originates from the largest bronchi, whereas medium-pitched rhonchi that originates from the medium-sized bronchi, and sibilant rhonchi that arise from smaller bronchioles. Crackles or crepitations sounds heard during inspiration, which is not cleared by coughing. So to hear crackles, we should have to first make the patient to cough and clear his airway. And if he coughs and he clears his airway, and if the crackles persists, crepitations are due to the presence of fluid in the alveolus or in the air tubes. There are of three types: fine, medium, and coarse crackles or crepitations. Bronchial breath sounds. This is a harsh, clear breath sound that is equal both in inspiration and expiration. It is due to the separation of the vesicular component of breath sound when alveoli are not functioning. Amphoric breathing is a high-pitched metallic toned bronchial breath sound heard on auscultation, and it occurs in open pneumothorax or in the cavities. The other thing is about vocal resonance. Vocal resonance is classified into two: bronchophony and whispering pectorality. Increased vocal resonance occurs in consolidation, collapse, and tumor. In this case, we ask a patient to say 99, 77, 44, and the like, and we auscultate the chest. And if there is increased vocal resonance, there is underlying consolidation, collapse, or tumor. Or when there is a decreased vocal resonance, it might show effusion or pleural effusion. The other is whispering pectorality. When a cavity communicates with the bronchus, whispered words are clearly heard at the earpiece. So we ask the patient to whisper, and it is clearly heard by auscultation. So that's called whispering pectorality. Pleural friction rap. It occurs along the breathing pattern, and it's important to differentiate between left anterior pleural friction rap from pericardial friction rap. So this is the order of auscultating lung fields. Just like a percussion, we should have to go in zigzag pattern, and we should have to auscultate both anteriorly and posteriorly. So in each place, we should have to auscultate for one full breathing, both in inspiration and expiration at a single point. This is how to differentiate different types of breath sounds. In a normal air-filled lungs, vesicular breath sounds are heard over most of the lung fields, and bronchovesicular sounds are heard between the first and the second interspace and anteriorly, and the bronchial sounds are heard over the body of the sternum, and the tracheal sounds are heard over the trachea. This image is a summary of how to differentiate different breath sounds on the chest based on the duration of sounds, intensity of expiratory sounds, and also pitch of expiratory sound, and also location. Vesicular breath sound is normally it is soft, and inspiratory sounds lasts longer than expiratory ones during vesicular one, and it is heard over most of both lung field areas, as we have said above. Bronchovesicular sound, it is intermediate in intensity, and inspiratory and expiratory sounds are equal, and it often is heard on the first and the second interspace anteriorly and between the scapula posteriorly. Bronchial breath sound is loud, and it's relatively high pitched, and the expiratory sound lasts longer than inspiratory ones in bronchial breath sound, and it's heard over the manubrium of the sternum. Tracheal sound, which is not used most of the time, and the inspiratory and expiratory sounds are equal in this one, and it's very loud, and it's relatively high pitched, and it occurs over the trachea and the neck. This is a summary of pediatric respiratory system physical examination. Please refer to Barbara Bates for further explanation. Thank you.